So, hello everybody. Thank you very much indeed for joining us in this most recent of our 39 Essex Public Law webinars. As you can see from the holding slide, which I'm going to get rid of in just 1 second, this webinar is about decision support for doctors in the context of stretched resource. And I'm incredibly glad that I'm being joined, and I'm very grateful to Chris Danbury for giving up the time for joining us by Dr. Chris Danbury, who I'm going to allow to introduce himself, because my attempts at introducing people always go on far too long. So I'm going to stop screen sharing, and so we can expand and see Chris and all his multicolored glory. So hi, Chris.
Hi, Alex. Thank you very much. So I'm an intensive care consultant at the Royal Berkshire Hospital in Reading. Just a little bit about myself. I come from a medico-legal family. My grandfather was a doctor. My father was a barrister. My brother's a non-practicing barrister and now works as an investigative journalist. So I've been exposed to sort of the interface between law and medicine pretty much all my life. And I took it further about 20 years ago when I did an MPhil in medical law. And I've been a visiting fellow in health law at the University of Reading since 2005. So that's why I think you asked me to come onto this show, Alex, and talk about the interface between law and medicine. It's something I feel very strongly about, and hopefully I know a little bit about it, but we'll see.
Definitely. Yes, no, absolutely. I'll get into a full disclosure thing in 1 second about how you and I know each other as well. But just for people wanting to kind of understand how this is going to work, what we're going to do is Chris and I are going to have a chat. I'm going to gently cross-examine him, or at least ask questions which allow Chris to think about things. I suspect he will have some questions for me. We've got Q&As down the side. We're probably unlikely to be able to answer them as we go along, because we'll be focusing on the discussion we're having. If we can, we'll try and do them. Otherwise, we'll leave a bit of time to have a kind of general sweep up of questions at the end. I think one thing I should make clear on my behalf is I can't give advice on the facts of any individual case. I'll let Chris's conscience grapple with the facts of any, as it were, clinical case. Sorry, Chris, over to you. Just going to say something.
No, I was going to say, I can't answer specific questions about clinical cases because the details are so complex in my field. I'd need to know all of the data before I could make a realistic comment.
Yeah. The full disclosure thing is that I sit on the Legal and Ethical Policy Unit of the Faculty of Intensive Care Medicine, which Chris both set up and chairs. So that's one of the reasons that we work together very closely in a medico-legal context. And we've also worked together closely in cases, in the Court of Appeal in the Supreme Court, involving essentially trying to get the courts to understand medical realities, I think is possibly the best one-line summary I can put there.
Yeah.
Yeah. And actually just in that context, Chris, and because I think quite a few of the people on this webinar may not necessarily have the same understanding of medical realities, in particular intensive care realities, as well, undoubtedly you do, and I may possibly have some tenuous grasp based on our work together. Just as a kind of opening question, for those people who aren't familiar, can you just give us a picture of what intensive care is?
Sure. So intensive care is a young specialty. It's only been around for about 60 years and has had specialty status in the UK for the last 20. And the faculty that you mentioned is 10 years old this year. So it's young, but it's one of the last general specialties within the hospital. So we take the sickest people from every other specialty in the hospital. So we have to understand where they come from, what the trajectory of their illness is, in order to try and get them over the acute deterioration that's resulted in them coming to us. What it isn't is a room full of ventilators, which you may have gathered from some of the pictures in the press over the last couple of months. So the emphasis is on care. So we're looking at all aspects of the patient. And those include the physical aspects like respiratory support, cardiovascular support, but also the psychological support that's needed. And then really importantly, rehabilitation following their acute illness. Intensive care, critical illness is a life-changing event, and you very rarely go back to the same life that you had before whatever critical illness brought you to see somebody like me. And in lots of ways, it's where all of the questions and decisions from other specialties get focused down into a very fine point, because you can't dodge and you can't delay making really life-changing, life-ending decisions. So it's the specialty par excellence where you have to make decisions, you can't duck them, and you can't postpone them. And that's really, that's my interest. That's where I come in, and understanding the why and the how people make decisions, and the area around that is my major interest. I don't pretend to understand it all. I don't think anybody understands it all, but hopefully I've got some thoughts that I can that will help people in the audience.
Brilliant, thank you. Just on ventilators, just because it's such a it's such a thing that people have got. I don't want to use the word fixated, but it's something which is such as it with a public face in some ways. Can you just give us an idea of roughly at the moment what percentage of patients on, for instance, your ICU would be on ventilators?
Percentage, that's difficult because it's changed on a day-to-day, week-to-week basis. But and it also depends on what you mean by ventilators. So we talk about respiratory support. So simple respiratory support would be just giving somebody a face mask of oxygen, or maybe a couple of probes in their nose. Then we move to what's called high flow nasal oxygen, where you're pushing a large amount of oxygen into somebody's nose, up to 60 litres a minute. And then you can move on to non-invasive support, which you may have heard of as CPAP or BiPAP, which is a face mask, and you're delivering extra pressure. So in addition to the oxygen, you're delivering pressure to the face and the upper airways. And then the final level that you'll see in most general intensive cares is invasive ventilation, where somebody is sedated. They have a plastic tube put down into their windpipe, their trachea, and then the ventilator takes over the respiratory support. There's one further level, which is ECMO, extracorporeal membrane oxygenation, but that is limited to a very few centres in the UK. There's about 5 of them, and they're very, very strict in their admission criteria, because going on to ECMO, if going to intensive care is a life-changing event, going on to ECMO is a life-changing event squared and cubed. So it's a very, very big deal. So they're very, very picky about ensuring that only people who will really benefit from ECMO will go on to that. And the modern ICU ventilator is not what you would see in the average film. It's not something that sits on the side with a weight and a bellows going up and down. It's a very, very sophisticated piece of kit with very complex computer modeling to try to ensure that we do as little damage to people's lungs as possible. It's not something that can be just rustled up by a vacuum cleaner manufacturer over a couple of weeks.
Mentioning no names.
I didn't mention any names at all.
Yes.
But they're very, very sophisticated pieces of kit. And if you wanted to buy an ICU ventilator, then a modern ICU ventilator, then you probably have to shell out somewhere between 25 and 40,000 pounds. So they're expensive and complex.
Yeah. And then just one other piece of orienting thing, and as you know, I'm an enormous capacity nerd. Kind of, again, what sort of percentage of people on your ward, on your unit rather, would have capacity to make decisions about various medical interventions? Do you think?
Very, very few. So if you divide the patients into patients who come to the unit electively following an operation and emergencies, the elective patients will have had capacity to make the decision about admission to ICU before they go for whatever elective procedure they've had. They won't understand what intensive care is until they've actually been a patient there, but they will have been able to make a capacitous decision. Patients who come to us as emergencies, the overwhelming majority lack capacity to make any decisions at all. And that's down to the disease process that has led to their referral to intensive care. I would say somewhere around 80% of the emergency patients lack capacity. And that may be an underestimate, but it's certainly, it's not less than that. So we have to act in patients' best interests pretty much all the time. There will be invariably at least one patient on the unit who lacks capacity at any given time. And it may even be the elective patients I talked about before, because when you have undergone treatment in an intensive care unit, you generally have to be sedated. And that sedation and, again, either the operation or the disease process is likely to make you lose capacity. So the vast majority of my work is making decisions about people who can't make the decisions for themselves.
And one thing which really struck me in the context of the Y case in the Supreme Court, the case about when it was necessary to go to the Court of Protection in relation to decisions there about clinically assisted nutrition and hydration, but the logic could be seen to apply more widely. When the faculty intervened, the Faculty of Intensive Care Medicine intervened and the evidence was put before the court, how many people in this country will end up dying in intensive care? Because as it were, it's the end point, it's the point you were describing, of where the most serious patients end up and the most serious things are done. It was a very high, it was a strikingly high percentage.
Yeah. So if you look at the data that's come out of ICNARC, which is the Intensive Care National Audit and Research Centre, they show that there's a mortality on intensive care of about 20%. And there's an additional 5% of patients who will leave intensive care but won't leave hospital. But if we just concentrate on the patients on ICU, if you then look at NHS Digital's information, the number of admissions to intensive care in not this year, but the last year that we have data for, is about 300,000. So what you're looking at is about 20% of 300,000 is 60,000 deaths per year on intensive care units in England and Wales. So that's a staggering amount. And then to go further than that, if you look at some of the papers that have been produced over the years, so the Ethicus paper was done by Charlie Sprung. Ethicus 2 is just about to be written up and published, and I was part of that group. And that looked at end-of-life decision-making in intensive care units across Europe, and Ethicus 2 across the world. And end-of-life decisions on intensive care occur in around about 70% of deaths. So 70% of that 60,000 that we talked about have had somebody like me making a decision about treatment withholding, treatment withdrawing, limitations of treatment, something. So that's a huge number, and that's every year. And then to make it more complicated, if you look at the Conflictus Study, which is again another study that was sponsored by the European Society of Intensive Care Medicine, Eddie Azoulay was the lead author on that. It suggests that a similar proportion, so 70 to 80% of patients where a decision has been made about end of life, results in some degree of conflict about that decision. And the conflict may be very, very simple. It may be within the family. It may be between family and the ICU team. It may be between the ICU team and the referring team, or any one of those combinations. And the conflict may be very, very low level, that just somebody can't bear to hear what's going on. through to the cases that we've seen come through to the court. Aintree was the first one in the Court of Protection, Aintree versus James, where, as you know, I was the expert witness in that case. And then the faculty intervened at the level of the Supreme Court. So that was the first ICU case, and certainly first that I'm aware of, mental capacity case following the MCA to get to the Supreme Court. And that's been very interesting. And subsequent cases have really allowed us to try and understand the MCA and the role of the intensivist much better. And I think that's what we're here to discuss.
It is, and there's so many rich things coming out of that I want to sort of take in stages. I definitely want to come back to conflict and thinking about conflict and how one can resolve conflict appropriately. And that's what we'll put a marker down, because I think that's an enormously important thing. I think, though, just one thing in terms of, again, orienting, because obviously in England and Wales, we've got decision making which could be done. Either you yourself could make a decision by way of advanced decision to refuse treatment, or you could appoint a proxy, the lasting power of attorney, or conceivably a deputy could be appointed for you, although a deputy could never make decisions about life-sustaining treatment. I'd just be really interested, and I think other people here would be interested, I mean, as an extremely experienced ICU consultant, how often do you come across a situation where you've got either an ADRT, which is sitting there, an advanced decision to refuse treatment, which is clearly valid and applicable to the thing which is under contemplation, or an attorney for health and welfare saying, it's my call? How often does this come up in your average, well, let's not say week, maybe non-statistically important?
Sure. It's infrequent. If you'd asked me this 5 years ago, I'd say that I've never seen one. But they are starting to come through now, and when they occur, they're very helpful. Although interestingly, one of my more recent experiences with a patient who had appointed one of her friends actually as an LPA, health and welfare LPA, although the patient lacked capacity, the friend felt unable to actually make the decisions that she was had been given by the ADRT. And I found that very, very interesting. They are coming through, they do exist, but the people who are the donees, the people who are the advocates, find the intensive care environment very difficult, very challenging, and enormously stressed to participate in end-of-life decision-making. So I wouldn't try and stop them from being part of it, but it is noticeable how difficult it is for them. I mean, it's hard enough for me, and it's my job. And I have somewhat more understanding of what goes on in an intensive care unit than the average person. But trying to help and support people through making the correct decision for the patient is tricky. So 5 years ago, none. Now increasing numbers, but still small fry, still less than 1%.
So when you say small numbers, are you talking about both advanced decisions and powers of attorney? Or
Yes.
Yes. And actually that point you raise about attorney, and I think I've described it somewhere else as attorneys freezing, I think is actually so important from a legal perspective, partly because it's just not recognised in any of the guidance which exists at the moment. Yep. So, for instance, the MCA Code of Practice at the moment bangs on and on about, and I understand why, it's terribly important to understand if there is an attorney, it's as if they're the patient. Yep. Similarly, the guidance from the Office of the Public Guardian really goes emphasising this idea that it's effectively the attorney's call unless there's proper reason to consider they're not acting in the patient's best interest, at which point, unless you can get a sensible agreement, you need to go to the Court of Protection. But no one seems to recognise this really, a really important phenomenon, which you're not the only medic to have mentioned it to me. And I think one concern as a lawyer is what happens at that point in terms of, are the medical team then themselves frozen, going, oh my God, what do I do? I've, as it were, got the decision maker, there's the attorney who should be making this decision, but they can't. So my strong, it's not strong advice, it's the very clear position. It's at that point, it's as if the attorney they're not making the decision. It reverts back to the normal decision-making structure in which you're taking into account as best you can the views of the attorney, not least as it were the person hopefully best able, or one of the people best able to relay the patient's wishes and feelings. But you're back in Section 5 collaborative zone. But I'm really glad you brought that up, because I think it's a phenomenon which was under-recognised because of the importance of trying to emphasise if the attorney's there, you, Dr. Danbury, should be talking to the attorney as if they were the patient.
Yeah.
And then actually just one question came in a couple of minutes ago, which I think is really, if I may just feed into here, which is,
sure,
how often do you feed IMCAs into the best interest decision-making process? Because obviously IMCAs have to be instructed if there's no one, if the person is unbefriended, as it were, there's no one professionally involved in the person's care. How often does this crop up?
Now it's very interesting, because it depends on where in the country you are, and it depends on the experience of the local IMCA service. Now our local IMCA service doesn't come to the ICU in Reading terribly often. It could be partly because I'm there. I hope not. But I think that different hospitals have different experiences with different IMCA services, so I don't think it's possible to generalize. I would say that I think it's likely that the average IMCA is going to have very little exposure to intensive care and very little exposure to the decisions that are made on intensive care. The only analogy I can think of is that if you look at GPs, the average general practitioner will have one of their patients go to intensive care every couple of years. So if we assume that it's safe, so the same for the IMCAs are likely to be going to intensive care only once every couple of years, which is likely to be a very, very stressful experience for them. I'm sure that there are exceptions. I'm sure there are IMCAs who go to intensive care on a regular basis. I'd be delighted to if there was some sort of national pool of IMCAs who could specialise in this area. That would be very helpful. But my experience of them is that they are often frozen in a similar way to the frozen advocate that we talked about before, and they defer back to me as an intensive care consultant, which may be fine, but equally sometimes leaves you feeling, well, okay, if you're just going to say, do what you think is the correct thing to do, doctor, then I wonder, there must be something more that they can help, and something more they can offer.
Well, thank you, Chris. I mean, I know, because I recognise a couple of names on this, that I am not. I'm not going to reveal names on here, as it were, for GDPR purposes, but I know that there are some really good IMCAs on here. And I think one thing I would just emphasise for IMCAs who find it possibly difficult there, I would really strongly recommend you read Jackie Cowley's book. And I also did a little interview with her, a recorded interview with her about her experiences of being an IMCA. She's particularly specialises now in prolonged disorders of consciousness cases. But also she also does other aspects. And I think one of the things she would want, if she was here, to draw out would be the extent to which one of the things that the IMCA is assisting with you with is, as part of the team, is, as it were, assisting you in understanding the patient. So what's important about the patient. So it's sort of interesting that you sometimes might perceive it as the IMCA's feeling frozen because they don't quite understand ICU. But in a way that, to me, that is almost the sort of wrong end of the, that's not what they're there for. They're supposed to be as part of, you're the expert in ICU. Yeah. They're the expert in as much as possible in being the person.
True. Okay. No, that's a fair point. I think that my normal working environment is so alien to so many people that it's a very strange atmosphere. It's very strange to come into an intensive care if you don't understand it. But I agree with what you're saying, and certainly the way I try to describe it to my colleagues is that as an intensivist, I understand the medicine. I've been trained in intensive care medicine. I've been a consultant for 18 years. So I hope I understand the medicine, but
if you don't, I don't know who does, frankly. So yes.
But what the thing that I don't understand is the person. So the patient in front of me, let's say that they're in their mid-50s, if they've got a family with them, then their family will have known them for 55 years. So they will be the expert in that person, even though I may be the expert in the disease processes that brought them into intensive care. So, and that's, I think, where we're coming onto this, I'm sure, but that's where the decision-making process leads us to. So I can understand the pathophysiology, I can understand the trends of the blood tests and the physiological parameters. I can see what's happening or what's likely to happen, but I don't understand the person who's lying there in the bed. I've never played football with them. I've never been out with a drink with them. I don't know what they want for their birthday. So I'm not an expert in the individual. I may be an expert in the disease process that's led them there, but I'm not an expert in the individual. And it's bringing those two facets together, the psychological, the emotional, behavioral, the things that make the person, together with the pathophysiological processes that put them on the intensive care unit. It's the key to making the correct decision for the individual patient. And that's certainly the approach that I take, and that's what I teach to my trainees.
Thank you, thank you. I'm delighted you said that, because I think that would be exactly how I would conceptualize it. I'd just be really interested, I mean, we've been talking about the decision-making process and this really clear emphasis on the person and who they are. Can you, I mean, over your 18 years as a consultant and prior to then, have you seen a shift in how, so we're talking about incapacitated patients here. Have you seen a shift in how this decision-making process is undertaken?
Yes. So I will have been a doctor for 30 years this year, come July, which still astonishes me. When I first qualified, it was still incredibly paternalistic, and there are still elements of paternalism out there, but far less so than 30 years ago. I wouldn't have dreamt of saying anything to one of my consultants when I was a houseman without being specifically invited to do so, and even then it would probably be only to agree with whatever the consultant had said. In my unit now, we regularly have very junior doctors asking questions, not just medical questions, but asking questions of why should we do this? Why shouldn't we do this? What does the patient think? The sort of questions that are just a delight to hear, because they challenge you and they make you reconsider what's going on. Often I don't have an answer. Often I'm saying I'm doing this because based on the evidence that I've understood and based on my understanding of what's brought them into hospital and based and other aspects of their care, this is the decision that I think is the best to make at this time. But in the same breath, you have to agree to change your view. If the facts change, then your decision should change. So we're on a journey within the medical profession. We're on a journey. We are far less paternalistic, I would say, than we were when I qualified. That's not the same as saying that I think that we've got it right. I think there's a long way to go, and I think there's a lot of people, particularly when you are not certain of yourself and comfortable in your role, where it's easy to hide behind the paternalism of the past. So I think we're better, but we can do more. And I would like to see all doctors going through some form of better training in collaborative decision making, and ideally anybody who is going to be involved in an acute job. By that I mean anybody who gets involved with emergencies, should really have a very good understanding of how to make decisions in somebody who lacks capacity to make decisions for themselves. I'm singling out the acute sector because if you go to patients with a PDOC, then you have time to consider what's going on. With acute specialties, there is a huge time pressure to make a decision now, because if you don't, somebody will die. Yeah. So I think that's actually probably the biggest drive to paternalism is this time pressure. That if you hear people talking about the golden hour for in heart attacks, where you have 1 hour to get the best possible return of heart muscle function for revascularization. You hear of the golden hour for after trauma and the golden hour after sepsis for antibiotics and definitive treatment. So there is definitely a time pressure, and during that time pressure, I'm afraid collaborative decision making has to take a second seat to getting the physiology stabilized. So I don't think paternalism will ever go away, because there will be drift between the time pressure of the acute setting and then the need for collaborative decision making once the patient is stabilized.
I'm just as a legal bod on this, I think one thing I'd interject there is it's reinforcing, I mean, I'll put a different spin on it, in the sense that it's reinforcing that what decision has been taken on the basis of reasonable belief about best interests at point A, you would need to be considering again at point B. Now you've got more information and more time. Yeah. And as the Lady Hale emphasizing in that Aintree case, it's always the question of, is this treatment in this person's best interests, which defines whether or not it's lawful. Yeah. And so the longer time you've got, I mean, you've described prolonged disorder of consciousness cases, you've got, by definition, really quite a long period of time to try and gather all the evidence before you've described in what you've just described now, the kind of real emergency, there's really very limited information you're operating off. And I think one of the things which always frightens me, actually, I use that word advisedly, is those cases where a decision has been taken in somebody's best interest at point A. Yeah. And everyone just goes, well, a best interest decision has been taken. Yeah. And one has been taken, well, we're not going to revisit now. And that I'd love to think you've never come across that in your medical career at all. I would be surprised if that was the case. And that always really alarms me, because it just shows that people, well, bluntly, haven't got the mental capacity yet. Yeah.
Yeah. Well, I mean, again, from my perspective, I think you've touched on it, in that you're not making a best interest decision. You're making a decision about the best interest of the patient who is in front of you. And that may be semantics, but I think it's important semantics. As you know, one of the things that I'm interested in, and I think is really important in terms of clinical decision making, is behavioral psychology, and how we frame questions and how we frame statements strongly influences how those questions or statements are perceived by others. So saying that you've taken a best interest decision sounds as though that's it, done and dusted. Saying that you are you are trying to determine the best interests of a patient over the duration of their stay in hospital puts a very different spin on it, and implies that it's a continuing process that needs regular reappraisal. Now, in fact, every decision that we make, everything that we do about a patient, be it on intensive care or on a ward, in a patient who lacks capacity, will be a best interest decision. So a decision to put a cannula in, a decision to start antibiotics, whether they're oral or intravenous or whatever. So any decision is a best interest, is a decision that has to be taken in the best interest of the patient. And I know that you know that, but I think there are some people who feel that actually decisions about best interests are somehow confined to an arbitrary subset of decisions, and it's not the case. There are these decisions being made all the time by every clinician of whatever grade coming into contact with a patient who lacks capacity. So it's important that the whole thing is taken in the round. You can set a direction of travel as a consultant, but it's normally that the implementation is done by somebody else. So it's a process, not a discrete event.
Yeah, thank you. And I think one thing I would really flag up there is, I don't think, well, there are two things I flag up. One, you are absolutely right that everything which is done in relation to a patient with lacks capacity must be now done in the name of their best interests, unless they've got an ADRT, at which point they themselves have determined it, and everything else must be done in the name of their best interests, which has the corollary that every clinician needs to be legally literate, which obviously lies not just in the hands of the medics to help, but the hands of the lawyers to help. And the other thing I would just add is to kind of flag that I don't think that you and your colleagues at the moment are frankly desperately well served by the Code of Practice, Medical Capacity Act Code of Practice, because it was written pre-MCA coming into force by a group of incredibly good, very well-meaning people trying to guess what things were going to look like. And in the years subsequently, we've had case law, which has come along and said, well, actually, Aintree says this is what the point of the best interest test is. And B, we've also just had loads and loads of experience about what it looks like. And one of the things I think we really have learned is people get very confused about what a best interest decision is, who takes it, who's the decision maker. And the MCA code just, if you tell one of your juniors to go and look at it, it doesn't really get there. I would give a small plug for the fact that the next iteration of the code will have an awful lot more detail there. The only small problem is it's held up at the moment because we're waiting. It's supposed to be joined up with the Liberty Protection Safeguards process, which is kind of on hold, well, slow. Can I move on? Because I've very, very deliberately not been asking you questions so far about COVID, because I think it's really one of the reasons I've very deliberately not been asking about them is I think one of the things I'd be interested in your take on this. People have got so understandably stressed about COVID that some of the core fundamental things about capacity and best interest have just gone. I mean, I've had lots of people in various contexts saying to me, well, has the Medical Capacity Act been suspended? But no. So one of the things I wanted people to sort of explore, us to explore, was kind of thinking about this in pure terms. But I'd be really interested in your take. I mean, so one of the questions we sort of framed as a topic was, what stresses are there on decision making at the moment? So in the context of COVID, where we are.
Well, I'll take that in two parts. So I think that there have been some very positives come out of it. And the positives that I can see are that the decision making that I've always done has had to take into account of somebody's frailty. But that hasn't actually been understood by other clinicians and also by the wider public. So I talked about the implications of being admitted to intensive care. There's a syndrome called post-intensive care syndrome, which as far as we can tell, is probably lasts lifelong after discharge from ICU and hospital. And it results in people having physical and psychological problems. You can show that they're physically weaker, less able to walk, have poorer balance, have worse fine motor skills. Then on a psychological problem side, have problems with memory, have problems with concentration. So this is just a small thing, but a small sort of description of post-intensive care syndrome, but it's a huge issue. And it's always been there. And patients who are frail to start with, for whatever reason, are more likely to suffer from worse post-intensive care syndrome than those who are less frail.
Can I just stop you there?
Well, I was just saying it's always been the case,
No, I was just going to stop you just to draw out the description of frailty, because I think one of the things which the judicial review, for instance, about the NICE guideline and the use of the clinical frailty scale drew out was potentially people not necessarily understanding, and I'm not claiming I do, but necessarily understanding frailty and what when you say frailty, what do you mean by frailty as opposed to what might be used in, as it were, the Sun or any other, pick your other tabloid description of frailty.
Yeah, sure. So what frailty isn't is the patient who's had, say, an inherited condition that means that they are less able to live independently. So the classic would be somebody with Down syndrome. Now a patient with Down syndrome may have to live in a sheltered accommodation, may need help with their activities of daily living, but is likely to be physically quite robust. So I would not consider that individual as a frail individual. And we regularly have people who fit that description coming through my intensive care unit. The reason being that they're predisposed to having physical problems, which make them more likely to come to ICU. So those patients, those people, they're not frail, but there are other conditions. Old age is one of them. The older you get, the frailer you get. I'm afraid that's an inevitability. But there are patients who have got chronic diseases that make them more frail with time. And there are a variety of diseases. We can go into the list if you want, but it's probably not helpful. But what we know is that patients who are physically, for a physical reason, and the physical reason may include a disorder of the mind, so people who've got Alzheimer's, for instance, who are physically unable to live independently, they will do worse if you admit them to intensive care. And particularly if you are bedbound, then you are likely to do really very badly if you come to intensive care, both during your time on intensive care and then afterwards. Now, that's not the same as saying that you wouldn't or shouldn't be admitted to intensive care, but it's important if you're going into this that you understand what's likely to happen at the other end. And so I look at frailty as one of those things, certainly historically, one of those things that's been important to discuss with the patient where I've been able to, and if not with the family, about whether or not the patient would actually genuinely want to be admitted to intensive care when they lack capacity. Now, the good thing about COVID, coming back to your original question, is that everybody's now talking about frailty. So the really helpful thing is that the discussions that I used to have at 3 o'clock in the morning are all being had in the cold light of day repeatedly over the last couple of months. So by the time somebody gets to be referred to me or one of my colleagues, the conversation has happened. And so we're in a far better position to understand the wishes and preferences of the patient. And so that has been enormously helpful. So just getting the concept of how physical frailty impacts on the likelihood of both surviving and then post-survival quality of life from COVID has been really, really helpful. Conversely, all of the activities that we've had to do to protect ourselves and protect other patients, and dressing up in PPE, personal protective equipment, has made it incredibly hard to firstly talk to patients, and secondly, because we've not allowed relatives to come in, having conversations on the phone has made the conversations about what's happening it also incredibly hard. And so on balance, it's far harder than it was before. Although people understand the concepts, getting the communication right is far trickier. And even what we're doing today, the body language is very tricky. I've not had the opportunity to talk to a relative via Zoom or any of the other platforms that are available. I've only had to speak to people on the phone, and talking to people about sort of potential end of life decisions on the phone is really, really hard. It's far, far harder than doing it face to face. And all of the non-verbal cues are just simply not there. And you're talking in a room on your own, and it feels so strange and so alien. So that has been I think the biggest single problem. But the process behind it has not changed. So the practicalities of implementing it. So the philosophy of trying to determine the best interest of the patient remains the same as it was before the COVID pandemic. But the mechanics of trying to achieve that consensus about what the best interest of P is harder.
And one thing, if I may, I mean, I think I just genuinely interested in your take on this, because one perception out there is that we've run out of resource, or we're about to run out of resource. And I very deliberately chose this as stretched resource. I just sort of, doing the work that I do, find it quite challenging to work out or to address people's perceptions about, are we about to run out of, for instance, ICU beds? Are we about to run out of ventilators? Oh God, what do we do? And I'm sort of interested to the extent to which, for instance, family members talking to you are thinking about that, or your junior doctors talking to you, because you're a senior medic. And obviously we've got, as a senior medic, one of your jobs, you know this, is to support your juniors. And it's that, the extent to which that is being part of the mix.
So there's no immediate worry about running out of capacity to ventilate people with COVID-19. And I've chosen my words very carefully there. The standards for intensive care in the UK are covered by GPICS 2, which is the Guidelines for Provision for Intensive Care Services version 2 that was published last year by the Faculty of Intensive Care Medicine and endorsed by a number of other organisations, including the Intensive Care Society. We cannot deliver intensive care medicine according to GPICS standards at the moment, but we can treat anybody we think would benefit from treatment in intensive care who comes in with COVID-19. Now, the way we've managed to achieve that is by cancelling elective work to free up the resources and the personnel to ventilate people in intensive care over the last couple of months. So you're asking a two-part question. If we had stuck to the existing pre-COVID resources, then those would have been exhausted a long time ago. Using my own intensive care unit, we have a maximum of 19 beds, and the peak number of patients we had, I think, was 35. And we achieved that by ventilating patients in the theatre complex and by being supported by our anaesthetic colleagues, both anaesthetic and theatre nurses and operating department practitioners. So the support of those individuals in particular allowed us to provide a basic level of intensive care medicine to any patient who needed it. And when you look at the government's graphs of saying, oh, we're at 40% capacity, that's 40% of that surge capacity, not 40% of the preceding capacity. If you want to see more data on it, then Andy Rhodes, who's a professor in intensive care at St George's, published a paper in 2012 looking at intensive care provision across Europe. And the UK has got 6.6 critical care beds per 100,000 population, and is very much in the lower quartile of Europe. And you compare it with France, who I think have got 11.2, or Germany, who've got either 27 or 29 beds per 100,000 population. So we have doubled, possibly tripled our intensive care capacity in this country to cover COVID. And that puts us at probably about 20 beds per 100,000 population. That's less than where Germany started with. So we have got the capacity. We can still do it. We can do it again. If there's a second peak, we will do it again, but we will do it at the expense of elective work. So that's not a decision for me as to how many critical care beds this country needs, or even an individual hospital needs. That's very much up for the management of the individual hospital and for NHS England and the devolved administrations to decide what is an appropriate number of intensive care beds. But will people like me do our very, very best to treat everybody that we possibly can? Yep, absolutely we will. If you need an ICU bed, we will provide you with an ICU bed. It may not be, it may not fulfill GPIC standards, but we will do our very best to get as close to those standards as we possibly can. And that's right across the country.
Thank you, Chris. And I mean, it's a really important thing that people understand, because I think one of the things that certainly I have been learning is the extent to which there are quite substantial public misconceptions about things. So it's really helpful to get that very clear answer. I mean, you've mentioned the possibility of a second peak or a second wave. Just trying to think it through in terms of the title of this webinar about support for medics. What more, so as it were, what, if anything, can lawyers do to help you, or what can senior medics do to help more junior medics? What, if anything, in terms of decision-making in relation to individual patients? I'm not talking about population level, I'm not talking about trust level, I'm talking about face-to-face with individual patients. Drawing on what you've been talking about, drawing about, you know, the core principles, and then what you've learned over the last couple of months. What do you think we could do? Is there anything that we could do better? I mean, together, if we're trying to think of this collaboratively. And I'd also include advocates here, because we've got a lot of advocates on this webinar in terms of making better NCA decision making.
Yeah, I think understanding people's wishes and preferences beforehand, I think that's an absolute key. So just on an individual lesson, but individual basis, I think understanding the wishes and preferences of your families, I think that's a good starting point. I think as a senior clinician, the thing that we have done, which I would strongly advocate to all of my colleagues, is actually we have moved to a resident rota for the duration of the COVID pandemic. So that means that there is always a consultant in the hospital all of the time. And that is being supported by our management. So it's not like we're doing it, we're being paid to be there, but I think it's important. It's really stressful getting into the PPE. It's really stressful being in PPE for a long period of time. So having access to a senior decision maker on site, I think has provided a lot of support for the nurses, especially the junior nurses and the junior medics. So as a clinician, that's the single most important thing that I think we've done is be resident. So it's not on call, we're on site. I think there needs to be a better understanding of the different types of decisions that can be made. I know we're not going to talk on a macro level, but I do think it's important, and I think this would be really helpful where the lawyers could help the medics to explain to the medics within what we understand of the law is what decisions should be left to the individual doctor and what decisions should not be left to the individual doctor. So are all decisions devolved down to the poor F1 who's just graduated 2 months early with everybody else disappearing, or should actually different categories of decision be left to different people? And if so, how do we construct a framework that allows people to understand who should be making decisions at any one time? So is it that only consultants should be allowed to make decisions about admission to ICU, or should it be any doctor, or should it be a clinical ethics panel, as I've seen advocated, I think in the questions, but also I've heard mooted by other people. So if you're referred to intensive care, should it be a clinical ethics panel deciding about whether or not you get a bed? Or one stage further, if you're referred to hospital, should it be a clinical ethics panel deciding whether you get a bed in the hospital? Or being discharged to a care home, the same analysis surely applies. Or is it a decision for a clinician? It's those sorts of questions. What would also be helpful is to understand whether or not there has been any change in the legal framework. We've been talking a lot about the medicine, and my understanding and my practice is actually the medicine has not changed. Is that the same from a legal perspective? And if the framework has changed from a legal perspective, how has it changed? So I think this, where we started with the interface between law and medicine, I think there could and should be more discussion about this area. Are there any hard rules? And if there are not, then okay, maybe that needs to be said so that people know that there aren't any hard rules, and it comes. I mean, it always does come back to the individual decision making, making a decision at a time, but that probably needs to be spelt out to people.
Yeah, I mean, I think that is a really critical point in terms of, and I've got to do something in a couple of weeks' time on a webinar for the National Mental Capacity Forum, and we were having a discussion about it, a planning discussion the other day, and it's sort of public health and human rights and capacity, like how does it work? And actually, one of the people on the planning call was, could you please start with an ABC of what actually has changed in the law and what actually hasn't changed in the law? Because I think my impression is people have been so caught up in different things that actually in some situations, people are really unclear as to what bits of law are just there, as it were, statute, like the MCA hasn't changed at all. And so, for instance, just to reassure the advocates on the call, and I know you know this, Chris, but just to reinforce, if Section 37 Mental Capacity Act says serious medical treatment, if there is no one appropriate who could be consulted with who is not professionally involved in the person's care, NHS Trust has to commission an IMCA. I mean, I know you know that, but that hasn't changed. There may be practical difficulties. There may be, for instance, practical difficulties in the IMCA attending the hospital. I mean, there are all those kind of practical difficulties, but that fundamental legal structure hasn't changed. So the statute hasn't changed. Coronavirus Act has introduced certain things in relation to potential negligence liabilities of doctors. But the core stuff, which is very important, hasn't said anything, for instance, about liability were demand truly to exceed supply, and were one to be getting into the position that you have one ICU bed left and two patients, both of whom meet the criteria for admission for ICU. Like that, the Coronavirus Act doesn't deal with that. Various people have said, well, the statute law should provide for it, because otherwise it's in the gift of the courts to try and work out what to do, which puts someone in your position or a more junior doctor, particularly more junior doctor, in a very difficult position. So, I mean, I'm not going to go into that in more detail, but I mean, there's that issue which Scott's about. And then I think the other thing for me as a lawyer is what the last couple of months have really brought out, is what is already in the case law, this evolution of, we've understood post-Aintree, in which you were involved, I was involved on behalf of the faculty as well, of standing in the shoes of P. And the more you do that, the more the focus is on what the person would have done, the more you do get to a point where you have a situation where it might be blindingly obvious what the person would have done, but you, the medic, say it's not clinically appropriate.
Yeah.
And there's that discussion there about the need for clarity on your behalf, the medical side. As a lawyer, I'd be saying, and I know you know this, but some people need to think about it. The lawyers or the medics need to be clear. Are we talking clinical appropriateness here?
Yeah.
You know, we're the medical experts saying, I'm really sorry, this just won't work. Versus this could work, but we think it would be absolutely blinking awful for you. We therefore don't think it's in your best interest. At which point you flip over into, as you've described, the person or the family or the whatever being the expert in that person, saying it doesn't matter that there's a 0.001% chance of CPR working. That's what they would have wanted. They want to go. And we've had case law which is saying that. And I think some of the ramifications of that getting worked out in terms of what is and isn't clinically appropriate. Again, things which actually already gone on, this may, if we can use it as learning, may have helped sharpen that. But if we're going to equip medics to make MCA compliant decisions with the support of people around them, I think those are things which need to be fed in. And certainly for one of the things which I find, one of the drivers that I have for doing the work that I do, for instance, with you, is trying to assist medics in terms of framing the legal confidence to make sure that they have conversations with people starting on the right basis. Because if you start on the wrong basis of the conversation, you are in all sorts of trouble. is my mini legal lecture just doesn't end with that.
Yeah, no, I agree. Just recapping from a medic's point of view, the way I go through things is in my head is firstly, am I willing to offer this treatment to this patient who's there in front of me? And when I say willing, I'm thinking, does it have any chance whatsoever of working? And if the answer is yes, there is a vague chance that it might work, then I'll discuss it with the patient and see whether or not they want to go through all of the consequences of having whatever that treatment is. But if I'm certain in my own head that that treatment is simply not going to work, then I'm not going to offer it. And it doesn't matter how many times I'm asked by whoever, I'm not going to do it. I mean, the classic is antibiotics for viral infections. So if you've got a proven viral infection, then an antibiotic is not going to work. End of story. So you should not get an antibiotic. And the reason why you shouldn't get an antibiotic is because it's likely to select out resistant bugs in you, which will make treatment of a subsequent infection far, far harder. So, I mean, that sounds like a trite example, but actually it's a very real example. But there are similar, more complex decisions on ICUs. So there are situations where it doesn't matter whether the family or even the patient would want CPR to occur. I know that CPR has absolutely no chance of working whatsoever, so I won't do it. And the example there, just before anybody gets all up on their high horse, I'm talking about a patient who is on extremely high dose vasopressors, so drugs like adrenaline, noradrenaline, to support the patient's blood pressure. And when you get to the extremes of those sorts of drugs, if your heart stops, there is no way that you can restart it because you've effectively had a drug form of CPR continuing. So if your heart stops at that point, it's not going to restart. So there are situations where we will not offer stuff, but only when we know certainly that it just simply won't work. And once you get beyond that, as you say, we're back in the frame of the Medical Capacity Act and discussing the risks and benefits. Although I wonder what your views are on whether the Medical Capacity Act has actually used the correct language in terms of best interests, or whether we should be perhaps adopting the UN Convention's terminology on wishes and preferences.
Will and preferences, yes. Well, that's a fantastic thing to end on. And what I'm going to ask, while I witter on about that for 30 seconds, Chris, can you go through and just pick one question from the questions we've been asked to select out an answer? What I'm going to promise we do is I didn't mention this at the beginning. I'm going to gather together a slide which has got some of the resources that we've mentioned during the course of it. We'll also, I'm going to promise us on our collective behalf, Chris and I, that some of the questions have been asked, if they're themes, we can also on that just respond, because we haven't got time to respond to all of these questions. But if there's a question that Chris wants to pick out, and I'll pick out a question as well. In terms of will and preferences, I think it's a really interesting, I mean, Chris and I have been on this journey together with the UN Convention on the Rights of Persons with Disabilities, because I, as it were, brought it to his attention that the CRPD, which we've signed as a state, we've said we are going to bring our law into compliance with it. I can't rely on it before an English court at the moment directly to say my rights under the CRPD have been breached, but I can say the state has said, UK said we're going to bring our law into compliance with it. And what I find really interesting is when I brought it to your attention, Chris, you immediately alighted on it and said, my God, that's just so much more useful a way of thinking about things, this person's will and preferences, than the MCA model of wishes, feelings, beliefs, and values. And I just find it very interesting that you latched onto that as kind of, actually this responds to me as an ICU medic in terms of when I'm asking myself, where do I go, what do I do in terms of this patient? And I know you and I have been promising for blinking ages that we're going to write something together about it, because we want to kind of follow up on that. But I think I would certainly invite people, if you want to know more about the UN CRPD, which I'd really invite people on this, to learn more, you can't do better than look at Lucy Series' website, Dr. Lucy Series, her Small Places website, which is, we've got really good resources about that. So Chris, while I was saying that, was there any of those questions, some fantastically interesting, some very pointed and very astute questions being asked, but any ones that you'd wanted to point out? I have one I'd like to pick out for you if you hadn't, but otherwise go for it. Okay, well, just a couple, just one very quickie. There's a comment here about surgeons are very worried about the issues about Montgomery. I would say that this is a plug. I would listen to, I think it's the Royal College of Surgeons doing a webinar. I think it's it's a couple of weeks on Tuesday. It might be next Tuesday. I can't remember. But look at their website. Lauren Sutherland QC is hosting that. She knows far more about Montgomery than anybody else because she was the QC who took the Montgomery case to the Supreme Court. I don't have the date to hand, but that's definitely worth signing up to. Conflict of interest. Lauren's invited me onto the panel, so you'll see me if you come onto that one. Other questions. Where do we get professional updates and training? Well, I've got a continued interest in this, so I pretty much eat, breathe, sleep this sort of thing. There should be something provided within your trust if you're a medic. If not, then look at the websites of the Royal Colleges. There's generally seminars and update meetings on most of the Royal Colleges. If not, then go to the BMA. The BMA do one, and I think the BMA's one is open to pretty much anyone. Your professional organisation should provide it, and if it doesn't, then you should be able to ask them to provide it. That's where I'd answer that one. Okay, Alex, what was your question? Well, there's a very interesting comment. Yeah. To the effect that is it likely that the very impact of not being able to communicate with patients and family in the usual expected way and the resulting feedback from them about the distress this creates, is it likely it's going to change future practice around patient-family involvement approaches to communication? I think this is a really important issue. And I think this is one of those examples where I'm frantically trying to find any silver linings at all to COVID clouds. And I think one of the possible silver linings here is the extent to which, if someone in your position, Chris, is having to find increasingly creative ways of dealing with this in circumstances where it's very difficult to think of anything, there are any fewer ways of effectively communicating than one person on the telephone at the moment. And then finding ways to grapple with that, and then having the PPE in front of you if you're face to face with the patient, how we respond to that, and how we, for instance, speech and language therapists might be able to help in some instances with other people thinking about communication, that might, but only might if we respond collectively, I mean, medics, lawyers, advocates, everybody who's interested, provide ways in which to ensure when normal service is returned, we've developed or assisted people to develop much better communication skills for the sort of difficult communications or difficult conversations that, Chris, you've been describing actually should always really have been going on. Those deep, meaningful conversations about what do you actually want, or what do you think your mum would have wanted. And so as always, if you can do it the most adverse way, if we can hold on to that when things get better, we might be able to do that in a better way.
Yeah, I think there's nothing that beats sitting down and having a direct person-to-person conversation with somebody. The next best thing is a direct person-to-person conversation with somebody, or preferably a group of somebodies who know P the best in the world. And there's no getting away from that. Understanding the body language, being able to look somebody in the eye, them seeing your body language. I think that is hugely important, and we've got to get back to that as quickly as we possibly can. However, there are always circumstances when you can't actually get somebody in time, and in that situation, I think the technology that we've seen and developed hopefully will help us communicate better, but it's not as good as being in the same room as somebody. But what you said about communicating and discussing your wishes and will and preferences before you get ill, even more important still, so that actually there's a very clear steer about what you would want as an individual when you get hit by a bus going into work. And
please don't say when, but yes, I think yes.
Okay. Well,
crystallize it actually. Yes.
Yeah. Well, I cycle into work, and I share a bit of my drive with 40-ton lorries coming past me at 50 miles an hour. So that's why I use that particular example. But my wife knows my will and preferences. So I think the discussion ahead of time is, if we can please hang on to that. So before you've ever seen anybody like me, I think having the conversation, having the discussion with your family, understanding what you would want, what you wouldn't want, particularly if you've been an intensive care patient before. So I noticed that there's at least one person in the audience who's been on ICU. I'm sure that there's more than one. You know who you are, and you know what it's like far more than me. I've never been a patient at an ICU. I've just looked after people like you. And you talk to people who've been patients, and it is a real eye-opener. If I can point people to Sarah Wake, who published something in the BMJ about a decade ago. She was a houseman, and she developed an asthma attack in her hospital and ended up on ICU. And she's got the most evocative description of what it's like being on an ICU that I've ever read. Similarly, David Aronovich describes, he wrote a blog piece, and he said, I can't remember the day, on Tuesday, I woke up and I was sane again. So that's a description of what it's like actually being a patient. I just want to pick up on one more thing. It's slightly different. Anne-Marie Irwin has asked a question. Do I think there'll be insufficient resources to treat patients? Well, it depends. If you're using GPIC standards, well, we're probably not meeting GPIC standards at the moment. But can we treat patients? Yes, I think we probably can. How am I going to prioritize the treatments? Well, the honest answer is I'm not there at the moment. I do an awful lot of scratching of heads and an awful lot of talking to people. And maybe, Anne-Marie, I'll come and ask you what your answer would be. I'm going to not answer that one anymore. But I think there are enough ventilators out there. Is my answer, but we'll be ventilating people back in operating theatres and elsewhere if we get a second peak. Of course, we may not get a second peak. That may be it, maybe over.
Well, should we end on that optimistic note? Chris, I'm exceptionally grateful to you for taking the time to talk to me. And I'm also really grateful to everyone on the audience for posing all these really interesting questions. I'm sorry we haven't been able to grapple with all of them. What, as I said, we'll do is I'm going to pull together resources that we mentioned during the course of it, and we'll also just, if there's specific things which really need an answer, we'll make sure that I'll lead on providing something which we can then either circulate or put up online. But I'm really grateful to the audience. Thank you very much, and thank you so much, Chris, for A, now answering all these questions, and B, if I may, cheesily, for all the work that you do. Both broadly and also for the patients in your unit. So thank you, everybody, and goodbye.
Thank you.